This is Paul Carpenter. Dr. Mohler, you mentioned the three well-known genetic tests from Prolaris, Oncotype DX, and Decipher. All of these, at least so far as I know, seem to take the scattershot approach of looking at a few dozen high-profile genes. Are there other forms of genetic testing, perhaps still in the works, that take a different approach other than the scattershot?
Well, I'm not sure exactly what you mean by scattershot, but
well, let me clarify. It looks at, say, as I recall, Prolaris looks at 46 different genes and has a rather complicated weighting algorithm. These genes are protective, these genes are susceptible, and comes up with a single number running it through their algorithm.
Yeah, Prolaris actually uses 31 genes that were selected a priori. These are genes that are associated with cellular proliferation. And so that's why I say it's not exactly a scattershot. Now, the Oncotype DX test looked at more of a scattershot of genes and then arrived at a group of 17 that seemed to convey the prognostic information. Decipher's even more of a scattershot in that it seeks to look at all genes that are expressed plus genes that are not expressed. And it allows the outcome to derive the predictor. So every one of these has a little bit different strategy and has different aspects of how much of a scattershot it is versus how much human thought went into I won't say biasing the assay, but directing the assay. So the most interesting thing to me is that these three major companies that we've talked about, I am very impressed with the way they're going about the development of these tests, how open they are, how participatory they are with the academic research community. And I believe they're even having some discussions about cooperating to see which of the tests provide the best information in which situation. So I really look forward to a future where we know which tests to use when, and most importantly, whether we can make these tests better as they're used more and more.
That sounds very hopeful. One thing that I wanted to respond to was less hopeful when you said, if I understood correctly, the NCCN does not yet have, I don't know, the budget or the expertise to evaluate this rapidly evolving field. And for the time being, we're going to have to depend on market forces. I worry about that. I wonder if you could comment any further.
Well, the biomarker development is a completely different field of medicine. It's under a whole different system of regulation by the FDA than is drug development.
Right.
The NCCN does not conduct clinical trials. NCCN is an organization that relies upon assembling panels of experts to review newly published information, and where sufficient information does not exist, to provide expert opinion as to the best way to go. The section on molecular testing in the NCCN guidelines, which is manuscript page 4, every word was very carefully chosen to not overpromise, to not be too excited, to be realistic, and to call for additional testing where necessary. So right now, it's a tough decision whether to use any one of these tests because they have not been rigorously tested as to whether they result in decision-making that is better or not. Most of the studies have been done using what's called retrospective prospective analysis, where you're looking at banked specimens where the outcome is known. Problem with prostate cancer, as you all know, is it grows so slowly, even when it's aggressive, that if we're going to use these tests to guide our future decision making and then look at an outcome like survival, that my grandchildren are going to have to interpret those studies.
Yes. I quite appreciate the dilemma or the trilemma facing you in trying to keep up with the evolving technology. And I was just curious to know, how do you guys keep up? And thank you for your answer.
This is Tony. How are you all doing? And Happy New Year, Dr. Mohler. I'd like to kind of elaborate a little bit on where you just went with retrospective views of trying to get some significant useful data. Clearly, randomized clinical trial is going to be a problem, especially in anything that involves an active surveillance patient, because they have to be so long and very expensive. Currently at SWAB, we're looking backwards, like you say, into the banks, and we're lucky to have the PCPT and the select banks that exist for us. But going backwards and looking and compiling some data and trying to arrive at some reasonable hypothesis for a clinical trial. Can you mention any other types of backward-looking banks that might be useful in helping us get some data until such an RCT can eventually be done?
Yeah, so there are many banks of archival specimens at all our academic centers. The problem is that a tissue biospecimen only has value if you have outcome connected to it. And so, again, I don't like to say what's difficult to do, but it's easy to collect a bunch of archival prostate tissue from men with cancer. It's harder to annotate those specimens with good clinical data so you understand exactly who it is you're looking at, and then it's even more difficult to follow them or to have followed them for a period of time necessary for them to declare whether whatever you're seeing in the tissue predicted that outcome or not. So I'll give you a simple example. One of the biggest problems in prostate cancer right now is the man who undergoes potentially curative therapy, and the only evidence of disease recurrence is a persistent or a relapse by PSA. Yet, a man who has a PSA detectable after failed curative therapy has a mean prostate cancer limited life expectancy of about 20 years. So, surprise, surprise, we can't get anyone interested in conducting clinical trials in this space. Now, you asked about active surveillance, and let's go backwards. That's even worse. An active surveillance patient with an autopsy-type prostate cancer that I talked about before, they're NCCN low risk or very low risk, they have about a 20 to 30% chance of progressing to some form of treatment. If that treatment in an active surveillance population is going to be nearly 100% curative. And so you're never going to know whether they actually needed to be treated or not, because all of them will be treated, and the cure rates will be virtually 100%. Now you're going to compare that to people on active surveillance who show no evidence of progression, and because you detected their cancer by PSA, it would be at least 10 years before they would have developed a nodule, and we know from then that the mean life expectancy is on the order of 12 to 15 years. So you can see the simple numbers game and the expense associated with any type of trials in this workspace, whether you're beginning with already acquired tissue or you're trying to do something prospectively, just because of how slow-growing prostate cancer is.
So, Dr. Mohler, that raises an interesting question about whether, and I'm not going to try and hold you to anything in particular, But has the NCCN committee actually discussed the issue of the possibility of changing the nomenclature of low-risk prostate cancer?
We have had discussions about that. In fact, there was a very excellent debate between Jonathan Epstein from Johns Hopkins and from Cornell, Mark
Rubenstein.
Mark Rubin, thank you. I'm so bad on names. Mark Rubin from Cornell, where they debated whether NCCN or AUA low-risk prostate cancer should be renamed, whether Gleason grade 3+3 = 6 prostate cancer, in essence, should still be called prostate cancer. And it was a very interesting debate. It produced a lot of questions from the audience, and they actually had each of them argue the other one's position, so it was also rather amusing. Now, we all know that there are Gleason grade 3+3 = 6 prostate cancers that are misgraded either because of sampling errors, or they possibly could turn into more aggressive cancer with time. So I don't think it's a good idea, and the NCCN panel did not want to get into a renaming. I think what people need to understand is that NCCN very low risk and low risk prostate cancer are extremely unlikely to ever cause your death, and should only be treated if there's evidence of growth. But our problem is we're still arguing about what should be the proper criteria for evidence of growth. And that brings us all the way back in a 360-degree circle to the molecular markers as to whether they can better detect a prostate cancer that's growing, rather than what I actually rely on quite heavily, which is PSA kinetics from the time of diagnosis. But there's a very excellent paper from Hopkins cautioning that PSA kinetics will not detect everyone whose cancer is progressing. But again, as I said before, if you find evidence of progression by biopsy and treat everyone, you'll never know whether you really had to treat them all. So I just want to convey to the audience that how difficult this whole area of investigation is. So I understand why it's frustrating to patients, it's frustrating to us, but it's also what makes it so interesting. And all the uncertainty connected with virtually every aspect of prostate cancer should empower patients, because you can evaluate the information and make whatever decision you wish, because no matter what decision you make, somebody will tell you it's right and somebody will tell you it's wrong. So you can make the one that's best for you, and then just don't pay any attention to everybody else.
I don't know if you actually saw this, but there was a very interesting paper from Australia just the other day on decision analysis, looking at the ways Australian men made decisions about whether they should or shouldn't have PSA tests based on the risk of the potential futures that they would be faced with if they were diagnosed or not diagnosed, or had to pay for certain types of therapy or whatever. I mean, it didn't resolve the problem in any way, but it did give some very interesting perspective into how patients thought based on their age and whether they'd had PSA tests before and things like that.
No, I have not seen that paper, but we need to do a lot more research about decision making.
Right. I'll see if I have your email address. I'll see if I can find I'll see if I can send it to you, because the author was kind enough to send it to me.
That would be great.
Paul, to get back to you, do you have another question?
Actually, this sort of ties in with what we were just arriving at, and that is the balance between quality of life and length of life. And that's a balance that every man facing prostate cancer has to come up with. Implicitly or explicitly, I think the NCC guidelines make some kind of determination that if PSA testing is done at this early an age, there might be so much overtreatment. If it's delayed until this late, and so forth. And I'm wondering, could those factors be made explicit? Have they been made explicit as to, for example, in Great Britain, there's the quality of life year, the QALY, I forget what it stands for. I'm wondering if NCCN has anything similar to make explicit its guidelines for what's overtreatment for too many people, undertreatment for too many people.
Right. So the term that you're trying to find is quality adjusted life years remaining.
That's it. Yes.
Right. And the problem with that is it is subject to the values of an individual. So
that was going to be my follow-up question. So
yep.
Yes, I quite
agree.
So
one man, you'll say to him, if you undergo radiation, you will have a 70% chance of being impotent 10 years from now. And he'll go, well, that's no big deal. I'll be 70. The next man will go, 70%? I'm not doing that. So the quality adjustment has to be done for each individual person, and it's very complicated to do correctly. And so typically that type of research is done on a population basis where when we're sitting in the doctor-patient in an examining room, you have to do it for an individual. And that's right. Where this is so difficult because statistics apply to the other 99 guys. They don't apply to me. And so what you have to do is present the statistics and then allow the patient to decide where they themselves fit amongst all those statistics. So
I couldn't agree more.
Yeah, I'm a big believer. My job is to educate patients. It's their job to decide what to do. At the end of a visit, I will say to them, if you want me to, like when I was younger, I'd say, if you were my dad, this is what I would recommend. Now it's like, if you're me, based on what I know, I think I would do this. But statistics, you want to use statistics to inform people, not confuse them. And you want to remember that all it does is give you you're painting a broad picture with statistics, but then you got to figure out where you're going to be.
Dr. Mohler,
I quite agree.
People like Paul and Tony and I are often on the receiving end of questions from patients about the side effects related to treatment. And one of the things that I've felt over the years is that we're all faced with a problem that the side effects, particularly erectile dysfunction and incontinence, that are presented in papers related to the treatment of prostate cancer are based on very different standards from institution to institution, and often underplay the significance of those side effects to the patients in the sense that if you can get an erection at all, you're potent, which certainly isn't the way most men actually think about being potent. Would you care to comment on that?
You raise a very, very important point, and that is that most urologists and radiation oncologists, because of what they do, believe in what they do. In other words, if I got a nail, find me a hammer. What you have to do as a patient is you have to inquire carefully about the individual experience of the treating physician using their modality. And if your physician is quoting, I always like to say, Dr. Walsh's experience at Johns Hopkins, then you need to go further. And there's some basic rules of thumb that Dr. Walsh actually advanced years ago, that a radiation oncologist or a urologist should have done in their career at least 100 of what they're proposing to do to you, and they should do at least one a month of what they're proposing to do to you. Now, I personally wouldn't let anyone operate on me that does a prostatectomy once a month and had done only 100 in their career. But you got to look at this very carefully, because the person that is the best radiation oncologist or the best urologist is the person who does the procedure relatively rarely but has really good results, because they've figured out how to do it safely. And that's who I think we should be studying. There are lots of people out there that do thousands of procedures wrong, and so you got to be careful here. Now, the other side of the coin, I just talked about numbers, experience. The other side of the coin is to specifically ask that individual, whether it's a radiation oncologist or a urologist, what their impotence rates are, what their incontinence rates are, what their rectal irritability rates are. Most importantly, what's the secondary cancer treatment rate? And if they can't tell you their own results, then you should go look for another person to treat you. All of us that are obsessive, compulsive, and good have databases, and we know exactly what our results are, because if we stray from what we think is good, we got to figure out why and make an adjustment. Did that kind of answer your question?
Yes, part of it. But the other part is it would really make people like me a lot happier if there were, if everybody used the same standards for measuring things like erectile dysfunction and incontinence. I mean, we've got a lot better than we used to be, but there's still a lot of variation in the way it's actually reported in published data.
Yeah, you're exactly right. When I came to Roswell Park 11 years ago, we put in place immediately, because we were starting a robotic program, a standardized way of assessing the quality of life of everyone. And we relied largely on Mark Litwin's instruments to do that, but there's not enough granularity in the UCLA instrument for erectile dysfunction, so instead we use the Sexual Health Inventory, the SHIM. But these instruments are out there, they're well validated, and they should be being used by everyone to do exactly what you're recommending, to use standardized forms of evaluating the side effects of these different treatments. Now, I want to come back to one thing that you mentioned earlier and about active surveillance. The NCCN guidelines, and I've been on a crusade about the need to right-size treatment. So what you don't want to do is treat everyone in whom you can diagnose prostate cancer. By the same token, you wouldn't want to never treat anyone in whom you can diagnose prostate cancer. But everybody lives in between those two extremes I just gave, and what we're trying to do is right-size treatment so that those people who have aggressive prostate cancer get a lot of treatment, and hopefully we can cure them. And those men who have a low-risk prostate cancer can avoid treatment until such time that we can demonstrate that their cancer's really grown. And we now know, with this growing active surveillance experience, which now exceeds 4,000 men reported in the published literature, that we have yet to have a single death once we recognize that we shouldn't have subjected the 3 patients in Toronto to active surveillance. We have not had a single death since in those 4,000 men. So we now know that active surveillance is safe for many men. And I'm very proud that NCCN led the charge for this, where we routinized our guidelines so that beginning in 2009, that men with low-risk prostate cancer and life expectancy less than 10 years, active surveillance was the only recommendation that should have been given. And then we expanded that 2 years later to where if it was NCCN very low-risk prostate cancer and life expectancy was less than 20 years, active surveillance is the only recommendation that should have been given. This has 2 things of benefit to men. It avoids the side effects of unnecessary treatment, but it will also make PSA perform better. If we quit treating people that didn't need to be treated, then it's one more step to quit diagnosing cancer that didn't need to be found. And so I'm very hopeful that we can right-size PSA so that then it'll be easier to right-size treatment.
So, Tony, one more question from you, and after that, we're going to throw it open to people with questions from outside. So, one more from you, Tony.
Excellent. Yeah, I'm going to back up a little bit here to the discussion of the multiparametric MRI. Of course, the discussion here was in trying to detect higher risk cancers. Obviously, I think I go back to Oliver Sartor, who said that we're really good at finding the aggressive cancers, and we're only pretty good at finding the less aggressive cancers. On the MT MRI, I'm going to apply that standard and sit there and say it seems to me like as though we should have good data today on where it detected high-grade prostate cancer, and we should have at least some good statistics there that show us that it's got some success. And then conversely, what are the challenges when we see that we don't see the characteristics in the imaging scans that tell us that it's high-grade, yet there's still a risk factor that it is?
So with the great advantage to me of the multi-parameter MRI is it allows you to carefully examine the anterior prostate that is not immediately accessible to the examination finger, nor is it sampled in the routine 12-core sextant biopsy that is focused on the peripheral zone, as we learned a long time ago is the best way to detect prostate cancer. The anterior prostate by ultrasound is very heterogeneous, so it's very difficult to see a lesion. So the real advantage, like now when somebody has an elevated PSA and a negative biopsy, my routine has been, when their PSA increases again, to then do a 12-core biopsy and then do 2 cores each of the left and right anterior prostate, which we call the transition zone. Well, if you think about it, the transition zone is as big as the whole rest of the prostate. And instead of doing 12 cores, I've routinely done 4. And I haven't really directed them at anything because I knew I couldn't see anything. Now, we were kind of assured because, in general, transition zone tumors are less likely to metastasize and often grow more slowly than peripheral zone tumors. But here we made a mistake, because now that we can image the anterior prostate, we're recognizing that in these men who we haven't before detected their prostate cancer but have a rapidly rising PSA, we're finding an alarming frequency of high-grade prostate cancer in that anterior zone that before we simply didn't know about. So I think it's appropriate to use MRI in this situation, but you still need to perform the biopsy. And I hope what you said is true, that we will then be able to cure these people because the literature has indicated that these anterior tumors are less likely to metastasize. But I'm not sure that's going to prove to be true. Again, remember, 3-parameter MRI is very new, so we don't have the follow-up necessary to prove that it's really of great value, although I believe it's going to be proven to be.